Hello, this is Joel Gonzalez, and I am the product specialist for MegaGen USA, and I'm also a trainer in our live surgical course series. As you can see here, here's my information. And more importantly, our website is iMegaGen.com. This presentation will be going over two very specific things: physics and biology, and how one definitively affects the other's outcome on your patients. So in order to do this type of presentation, we're going to have to compare and contrast different design philosophies that we've seen over the last 50 to 60 years, and again how what the results are and how they've affected the patient's outcome. So teeth are different shape, sizes, so forth: molars, bicuspids, centrals, canines, and so forth. But guess what? The patients, all they really care about is what you're looking at right now, a beautiful smile. And that's what we're all judged by in everything that we do. So MegaGen's mantra is excellence in a smile. So what are we really looking at here? What is our goal? Our goal is to give your patients back as naturally as possible their teeth. And as we all know, teeth have a biologic width and implants do not. So we have to talk about the different challenges and so forth regarding the bone, tissue, and so forth and so on, which we'll be doing here. Again, this will be a very detailed, comprehensive presentation. Really, what your patients are looking at are two things: pink and white. White aesthetics, okay, and then the pink architecture, which is, we all know, is papilla. So the question becomes, can we have this outcome every time? And as you all know, it's really not always possible, but how can we make this possible is the point and the challenge. Case selection and treatment planning is absolutely key, and the implant system utilized definitely influences the outcome as well. Okay, so let's get going. Periodontal biotypes is absolutely key as well. So let's look at quickly the different topics and the categories here. For gingiva and marginal bone, you have thick gingiva and thick bone. That's really an ideal scenario. You can pretty much do anything with implants there, because again, that's an ideal scenario. Thin gingiva and thick marginal bone becomes a challenge, but because of the tissue, but it's still doable. Thick tissue and thin bone, a little bit more of a challenge, and thin tissue and thin bone, the most extreme challenge. So what do we know so far? Factors contributing to crestal bone loss, problems we've had in the past. We know that microgap is an issue. We know that micromovement is an issue. So let me quickly go over what the categories are here. Microgap is a gap between the abutment and the screw, typically within connections that do not incorporate a Morse taper and a conical seal. Micromovement is movement that is realized between contact surfaces that is minute in distance. Stress force, stress is a measure of the average force per unit area of a surface within a deformable body on which internal forces act from within. And lateral force, side movement through shear forces. Bruxism, even denture patients can exhibit bruxism. So we're going to talk about all these different aspects and so forth in this presentation. Again, very comprehensive. So paradigm shifts that we've seen in implant dentistry. Number one is the surface. We've moved from pure titanium to a roughened surface with consistent surface roughness porosity. We've then moved to different connections, from an external hex to a Morse taper to an internal hex to a combination of the internal hex or some sort of internal connection and a Morse taper. I hear a lot of people say, well, all implants are the same, and that could not be further from the truth. Biologic width, we're going to look at that as well. Physiological space for ideal bone and tissue formation, for ideal bone and tissue adaptation, which is typically 2 to 3 millimeter zone. And the Anyridge system is a paradigm shift. So these are all paradigm shifts that we're going to be looking at. All right? Okay. So what do we know about crestal bone loss and about crestal bone preservation around implants? So we know what's worked so far is roughened surface is to the top. So as you can see in the design parameters of different implant companies that haven't had a surface roughness to the top, they are moving that to the top. So surface roughness is to the top now with no polished collar for maximum surface area. So you want a deep internal connection for increased surface area of abutment to avoid micromovement, as well as good indexing ability, which aids in lateral force dissipation. Platform switching, which is basically medializing the implant to abutment connection, and a deep Morse taper to have sufficient surface area for good conical seal and stabilize the abutment connection. Okay, and the Morse taper also does away with the micro gap. So this is what we know about crestal bone preservation and what seems to work the best over time. So biologic width, as we can see quickly and review that, was first discovered by Gargiulo in 1961, or not discovered, but observed by Gargiulo. But we're really talking about a 1 millimeter connective tissue area, a 1 millimeter epithelial attachment area, and then your sulcular epithelium, making that area the 3 millimeter zone that we talked about just a minute ago. So accommodating biologic width. So we have to sort of state where we are right now in order to proceed forward. So accommodating biologic width, we need to reduce or eliminate the micro gap, tapered internal connection for perfect hermetic seal or conical seal, what other people call it, no stress risers, functional load distribution throughout the implant connection. We want to eliminate micro movement. We want a stable mechanism for indexing and definitive seat into the internal connection. And again, like I just talked about, medializing the implant to abutment junction, which is basically platform switching, which creates a space for connective tissue and minimizes lateral forces. So different implant designs have come on the market to accommodate biologic width. So let's quickly look at that. This is an Astra. This is a micro-threaded implant here. This is an ankylose, a platform. Oh, by the way, this does have a platform switch to it and this bevel here, and you can see the surface roughness to the top. Okay, so that's basically everything we just talked about. It does have an internal connection on the inside there. So if you look here, this is an ankylose implant here. Again, platform switching, smaller type threads, if you will, sort of a widened platform switch. Look at the deep gap there as far as the platform switch goes. This is a bicon implant. Okay, people have talked about that as well. And this is a ITI type tissue level implant. Any implant that has a collar to it, similar to this, is basically a tissue level implant. All right. Now all of these again have the most of the four things in common, except this one right here. This implant here, because of the collar, it made it very difficult to try to deal with anterior aesthetics because of that polished collar there. Okay. So then this picture is great because it actually tells a story here, but we're going to get into that in just a second. But you can see here the abutment. This is a Straumann bone level implant with the taper here and the internal connection there. Okay, so again, we see the similarities between all these different implant designs. So what do bone level implants do for tissue? Well, this is called a deep well, and a lot of implants that don't necessarily get this type of result don't have the four attributes that we just talked about. But the implants that do have the four attributes that we talked about typically have this type of result. But one of the things that you can look at here is the big wide well that you can see there. Okay, and as you can see a little bit closer, this is just a beautiful soft tissue outcome. This happens to be a rescue implant. And let's go to the next slide here. And this is another wide healing abutment. That's how you get that natural emergence profile. Okay, again, look at that really just beautiful tissue, and that's basically performed with your wider type healing abutments. So again, like we just talked about, Astra, ankylose, Straumann, bone level implants, they all have and incorporate the things that we just talked about. Look at the Astra implant. I just want to point something out. Look at how it's sunken below the height of crest of bone. All right, we're going to be going over that in just a second here. Again, everything we just discussed, bone level implants, platform switching, internal connection, conical seal, and so forth. This is, again, the outcome of a well that we like to see. But again, now we have to look at the thread design and how stable can those implants be. This picture here tells a story, and let's get into that just one sec here. You can see this is a Straumann sort of history. This is a 2.8 collared implant to try during their research days regarding the biologic width. They said, well, let's have a 2.8 collared implant, and tried that one, and it came out well. The problem is this 2.8 collar, you had to actually sink the implant deeper than sometimes the tissue that you had. So this tissue level implant here, sometimes the collar would be sticking out, so they went to a 1.8 collared implant. But again, you have a Morse taper, 8-degree Morse taper here. You have this bevel here. But again, how can you get ideal aesthetics in the anterior with this type of implant? You really had to sink it to where this collar here was right at the bone level, and then the bone would remodel around this. And then they went to a tapered effect, and now they have Straumann bone level, which has basically no collar. So again, that is the paradigm shift. So quickly, let's talk about biologic width and the flat top interface that we see with different implant designs. Now, this was a beautiful outcome. This happens to be a replace select implant. Here is a tooth implant and a tooth, and a nice outcome. Let's look at underneath. Here's your x-ray of that exact implant, and here you see, because of the micro gap and the things that you don't see that we just talked about, you see some cupping, all right? And some other people call it dieback. But also your flat top interfaces and your create your micro gap scenario. So let's look at this x-ray here, which is really tells a great story. Here's external hex implants, and you see how the cupping effect around external hex implants was pretty prevalent. But you have an implant and then a tooth, and then a tooth, and you have another implant. So you never had these two implants right next to one another, because if you did, what would happen, you know, again, relative to the external hex. So now let's look at this implant or tooth right here. Here's an implant. Here's a little bitty tooth root that was kept on purpose through the implant, the treatment plan. And then here's another external hex implant. Now, what would have happened if we would have placed another external hex implant there? The outcome of this case would not be as it was. Okay, so here's your really nice papillary area, and you can see that, again, that was done on purpose to keep the bone there relative to that small tooth. Okay, so small changes, can make a big difference. Now, one of the things we want to talk about is, as we talked about MegaGen, what we have to offer. So throughout the history of MegaGen in 2002, when they first incorporated, and then they launched the Rescue implant, it was the widest implant system in the world. So MegaGen has a history of innovations, but this implant was designed out of necessity because your smaller implant types were fracturing. I'm not going to go into that right now, but we're going to go into the aspect of why they came out with this particular design. So it was also the shortest implant in the world. But one thing to note, the implant diameters were 6.0. It started, by the way, at 6.0, 6.5, 7.0, 7.5, and 8.0. All right, it is a single prosthetic connection, and they have wide healing abutments specifically for molars. Now, this is a molar implant only. Okay, again, shortest implant in the world as well. For vertical bone height challenges and so forth in the sinus and the IA area, this implant has a lot more surface area than your smaller normal size, or what we call traditional designed implants. We're going to be going through all that. But the Rescue implant did incorporate and does incorporate everything that we just talked about, which is, again, surface roughness to the top, bone level implant, which basically that's called platform switching, deep internal connection with your tri-lobe connections here, okay, and your conical seal, your Morse taper, or your 11-degree Morse taper here. All right, and here you can see a huge 2.5 millimeter abutment screw, because again, it is a molar type implant specifically. Now, the other innovative thing that MegaGen first came out with, again, when they launched the intermezzo implant, it was the thinnest implant in the world, just showing a little bit of again, the innovations that MegaGen has come out with over the years. So again, what do we know? Bone level implants were surface to the top, no polished collar. Deep internal connection to avoid abutment micro movement. Platform switching to be able to decrease lateral forces on the implant connection. And a deep Morse taper to be able to have no micro gap and stabilize the connection itself. So here's a picture of your Easy Plus and your, here's your Easy Plus, and here is your Rescue implant. And again, these are both bone level implants. All right. Again, what we just mentioned is your other one is your Easy Plus. Now, your Easy Plus, the reason I want to show this is specifically because this shows really good pictures of your internal connection, or your Morse taper. Now, this one is 95% similar to the Astra implant. Okay, it's again 11-degree Morse taper. It is compatible with Astra on the internal connection, but the difference between this one and Astra, as you'll see in a minute, again, here you see the 11-degree Morse taper, which when you split that in two, when you multiply that times 2 is 22 degrees. And again, compatible with Astra, excuse me. And it's different though because it's like an Astra implant without the microthreads. Okay, so if you look at this right here, there's your Easy Plus. There's an Easy Plus being placed. And the reason I point this out is because one of the things that I hear comments about and people don't like about the microthreads is the thinness of the walls. Again, I am not talking negatively about Astra. I'm simply talking about the design parameters of different implant systems. So if you see here, you can clearly see the microthreads, the microthreads on the implant, but the thinness of the particular wall. This is what I'm talking about regarding the microthreads, and you can see how that the Easy Plus is very similar, again, without the microthreads. And this will become relevant in a minute, as you see. So here's an example of where we've been. Here's your, again, traditional type of implant. You can see very small threads on there. And then here's your molar implants, which again are rescues. And let's get into where we're going now. So where are we going? So what do we ask for ideally in an implant system? We want less bone reduction, excellent initial stability, immediate placement, immediate provisionalization, if possible, in order to, again, start tissue training, immediate or early loading, faster integration, because guess what? Patients are demanding that nowadays. Earlier final restorations, less crestal bone loss, or again, if possible, zero crestal bone loss, less failure. You want a strong body for strength, okay, because these implants are going to be in the patients for the rest of their life. Better stability to lateral force, and zero screw loosening. Screw loosening is prevalent in implant dentistry because of, guess what? Bruxism and the physics of the different types of connections out there. So which system can give us all of it, everything that we're asking for? Well, here's the paradigm shift. This is the Anyridge implant system. So we're going to be going very, very much into detail regarding this particular implant. Now, this design philosophy mimics nature. In other words, there are trees out there in nature that are, you can see the wide, well, where's my cursor? There it is. The wideness of the roots. Okay, when a storm comes and so forth, it doesn't necessarily blow over. It might break here, something, but the wideness of the roots really holds the tree in place. The Anyridge is very similar with a wide body and the wide thread to engage a wider aspect of the bone itself. What we need to consider in implant dentistry is prosthetics. So we're going to look at this in great detail. Underneath that is your surgical aspect, okay, which is your implant fixture and surrounding bone, and the maintenance as well. You know, how to maintain the best soft tissue and bony result, which is connection and transgingival tissues itself. And one of the things we really want to talk about and take into consideration for the long term is your occlusion, basically, on these implants. So let's look at the surgical aspect of the implants and the surrounding bone. So we want to look at the macrostructure and both the microstructure of the implant design itself. So here's the anatomy of the Anyridge implant. Let's take a little bit closer look at it. We're going to talk about the 6 major differences that this implant has over other implant systems. So here's what we call the double offset for better peri-implant biotype and maintenance. We're going to be going specifically into each category in just a sec. The central core design, which is less reduction and more preservation of cortical bone. 5-degree Morse taper, which is very important. Again, a 5-degree Morse taper connection for zero screw loosening. Knife edge threads, very strong body with wider surface area, and a round and tapered apex area with no cutting surface. Okay? All right, so let's talk about the less reduction and more preservation of cortical bone. So here you can see 2 Anyridge implants being placed. Now, this one here is in the process of being placed. It's not fully seated yet, and this one is fully seated. Okay, these implants do have 2 main central cores of 3.3 and 4.8, and here you can see again your 4.8 core, and there you can see again the body not being seated. There you, however, see the core being seated, or excuse me, the core of the implant there, and you no longer see the threads. So the threads literally sort of disappear into the bone, similar to like a corkscrew, if you will, if you want to think about it that way. So why is this important? Because you're taking less bone away. Let's look at this particular implant here. A lot of different implant designs actually count on the cortical bone for their fixation, because look at the thread design and the thread pitch here. Okay, they're minimal threads, and look at the thread pitch and the thread design here. They're maximum threads with no threads up on top. And the reason is there's cortical bone here and there's cancellous bone there. So, as we all know. So, with the Anyridge, you're actually saving and taking less cortical bone away, which when you take less cortical bone away, you're actually increasing blood supply to the area. Now, quickly to review the sequence, if you will, of traditional implant systems. The traditional implant system, actually, let me just kind of burn through this. Each implant really engages a minimal amount of bone. So let's quickly look at this. Here's a 2.8 drill for your implant diameter 3.3. Okay, 3.3 drill for your implant diameter 4.0. 3.8 drill, final drill for your implant diameter 4.5, and so forth and so on. As your implant gets bigger, your drill gets bigger, so you're actually taking more bone away. So again, traditional implant designs are typically 0.7 millimeter larger than the final drills. So that means you're only engaging 0.35 millimeters of thread into the actual bone. So what does that really mean? Here's an example. Here's a 5x10 Easy Plus implant. This is one of MegaGen's implants. Look at the final drill is a 4.3, and then you have a countersink, and then you have a tap. So this is the full sequence of drills, again, for a 5.0 by 10 Easy Plus. So now let's look at the bony engagement that you're really getting. What did we just talk about? So let's take it as an example here. You can see a macro view of an implant, and here is the body. This line here and this line here is the actual body of the implant, and this outer line here and this outer line here is the thread engagement. So you're really only engaging 0.35 millimeters of bone, which together is 0.7. Like we just talked about, as an example, here's your 0.35 plus 0.35 is 0.7. So when you add up 0.7, that makes a 4.3 drill for an implant final diameter of 5.0. All right. The Anyridge system is totally different from other implant systems, or from what we call the traditional implant systems that we've seen thus far, and this is why Anyridge is a paradigm shift. Again, what did we just talk about? Your different designs. Now, because you're doing that, because you're taking actually less crestal bone away, you have this crestal bone preservation here, versus wanting to try to maintain your crestal bone by micro threads. So let's say you've really compromised how much bone you're actually taking away. Are your micro threads going to keep your crestal bone in place? Well, they're really not, because sometimes you do get cupping around these implants. All right, and the reason is because, again, the more bone you're taking away, the less bone you have, the less blood circulation you have, and so forth. All right, so here's a macro view of that, what we're just talking about. So the consistent tapered central core of the 3.3 or 4.8 with wider thread engagement saves that precious bone. So you're saving your cortical bone and your outer dimension of bone itself, having that wider thread engagement underneath, but yet a core, if you will, exposed to the outer diameter, or excuse me, to the oral cavity, and this is where you put your healing abutment and cover screw on. And again, this is just as a reference what we just discussed. Here's a clinical example of what we just talked about. This is compliments of Dr. Jonathan Kang. You can see these are implants here. You only see the 3.3 core here and the 3.3 core here. All right, here's another example. This is Dr. Neil Patel. Here's an actual sinus lift case. You see a small 3.3 core there and a small 3.3 core there. This implant was a 4.5 by, I believe, 8.5. Let me back up here, and this was a 5.0 by 8.5. Okay, so you can clearly see the implant stabilization. You're only removing a small amount of bone here, but you're getting maximum stabilization underneath that with your thread types. Okay, now this is an important picture. Why? Because look at your implant here. Look at your threads here. We're going to go into the actual density of the bone and so forth in a minute. But now what happens? Look what happens when you countersink your implant and you place it to final depth. You see your wider diameter threads here. This, I believe, was a 4.5 by 10 implant. But you can see the wideness of the threads, and now look at that. Here's your core itself, and you can clearly see the internal hex. So let's look at the schematics of everything we just talked about. Again, through the work and literature that's been looked at in the past, again, what you're really focusing on with traditional implant designs is the fixation with cortical bone at the very top. So what does that mean? Okay, again, a lot of implant companies are trying to incorporate microthreads into their implant design, thinking that it will keep it there. But what happens when you take too much bone away? You actually get that cupping effect. And again, now you no longer see, or rather, you're no longer keeping your cortical bone in place, and you do get that cupping effect. The question now becomes the cancellous bone underneath. All right, because again, you do get cupping around these sometimes with these implant designs, especially if it does have a micro gap. Different implant systems might have micro threads, but they may not have a conical seal to it. And that conical seal is absolutely key in crestal bone preservation as well, which we'll talk about again a little bit more definitively. So with traditional implants, you're actually taking more bone away, as you can see here. That's a good illustration here and here. So by compromising this thickness of bone there, again, you're compromising the amount of bone that you have and the end result. So my question becomes, and our question at MegaGen becomes, how can you actually achieve stability from cancellous bone and relieve pressure on the cortical bone? Again, because cortical bone does not react well to pressure, as we all know. So we want that guaranteed excellent initial stability, right? Okay, so let's look at the whole implant line from Anyridge. So here's 3.5 all the way to 8.0. Now we're going to focus on the 4.0 through 8.0 diameters, because your 4.0, 4.5, 5.0, and 5.5 all have the same core of 3.3. Your what we call super wide diameters come in 6.0 through 8.0. Now, this is very important. Look at the different implant diameter itself: 3.5, 4.0, 4.5, 5.0. So each implant is only a ½ millimeter difference in size, which is key for looking for that initial stability, because sometimes when you make too big of a jump, you're actually, again, putting too much pressure on the bone. So that ½ millimeter is absolutely key. So you can see a better picture here of just the core of the implants. Now, why is that important? Because you have basic minimum drilling for your actual implant placement. So each implant is now relative to the density of bone. So in other words, your 4.0 implant is your D1 bone. This is for D1 bone, because your 4.0 and your 3.5 implants, those two implants are traditionally designed. In other words, you have 0.35 bone engagement here and 0.3 in bone engagement there. So here, with your 4.5, it's actually a D2 implant, which is a little bit softer bone. So the softer the bone, the wider the implant. So core, their 5.0 implant has a core of 3.3, yes, but it's for your D3 bone, and 5.5 diameter implant is for your D4 bone, which is, as we all know, is the softest. So again, D1, D2, D3, and for the super wides, we actually have 2 D4s, which is your 7.5 and 8.0. And these, as we'll get into in just a minute, these are more for basically extraction sockets for your super wide diameter implants. But you can clearly see here the healing abutment lines, and I want to point this out right here. It's 10 implant diameters, 1 prosthetic connection, 0 screw loosening. Now, this will make more sense as we go on in the presentation. All right, so the core is key. So what does that mean? Here's, you can see a more definitive picture of your core. So you do basic minimum drilling to place these implants of 3.3 or 4.8. Now here's a little bit better picture. Here's your actual thread engagement. Now again, 4.0 is your normal thread engagement. 4.5 is a little bit bigger, 5.0 a little bit bigger, 5.5 a little bit bigger. But again, you've only drilled an osteotomy of 3.3. All right, so let's look at that. So your 3.5 implant is actually, again, 0.6, which you have 0.3 millimeter of engagement on each side. So with your 4.0, again, these two are traditionally designed. 4.0 implant, the final drill is 3.3, so you have 0.7 millimeter engagement. Again, 0.35 on each side, what we just discussed. Now with your 4.5, that's where it starts to change, because you actually, if you subtract 4.5 from 3.3 from 4.5, that's 1.2 millimeters, and divide that by 2, that's 0.6 thread engagement on each side, and 3.3 from 5.0, that leaves 1.7 millimeters, which is 0.85 millimeters thread engagement on each side. And again, 3.3 from 2.2, from 5.5 is 2.2, and that's 1.1 millimeters thread engagement on each side, because you can clearly see, look at that, look at how wide those threads are. But again, this is for soft bone, D4, D3, D2, and D1. And we're going to make more sense of that in just a sec. So quickly to recap here, you can see what I'm talking about with your wides as well. I'm not going to go into such detail, but your wides are really for mainly extraction sockets. But look how much thread engagement you have. So this photo of everything is key. Again, looking at your thread engagement is maximum surface area as well. Okay, so guaranteed excellent initial stability always. So what does that mean? You can clearly see from D1 bone, D2 bone, D3 bone, and D4 bone. You all know the difference in how they look and so forth. Here's a nice schematic of that. So when you look at the implants, again, each one is designed for each type of implant. So why is that important? Because this is the only system that actually gives you implant sizes with specific thread design that engages the cancellous bone underneath the cortical bone, therefore relieving pressure on the cortical bone. Different bone densities results in ideal initial stability with different thread patterns. And how's that achieved? All right, so you really have a knife thread with a rounded face. Okay, you see that rounded face there. So it's more like a sort of a sword, if you will, cutting into the, or engaging more so, the bone. So increased cutting efficiency during insertion. Once you place an Anyridge, when it grabs the bone, it really grabs the bone. Excellent initial stabilization, increased resistance to compressive force, minimized occurrence of shear force, and higher bone to implant contact. Okay, and the one thing I want to make sure that we talk about though is these threads are not too sharp, as you do not want the implant to redirect itself or cut into the sinus, for instance, or the IA, which some systems have a tendency to do. Current fixture thread patterns that are available on the market: standard V threads, spiral thread, square thread, buttress thread, reverse buttress thread, and locking screw design. Okay, now this is referencing Dr. Mish's book. Compression type of forces are the most favorable. Tension results in weaker bone, and shear forces results in the least beneficial least beneficial relative to the bone. Now, your single thread, double thread, and your triple threads, these really basically were the least favorable. The one that got the best results really was your standard V thread. So you really want to compare sort of engaging the bone with a nice sharp instrument versus sort of forcing its way into the osteotomy. For instance, a good example with a traditional designed implant, if you want to get really good stability, what do? You don't use a final diameter drill. You actually cut it, shorten one final drill to try to get better stability that way. But again, now what you're doing is pushing sideways. So what's the result? Surface area that has really much higher percentage than other implant designs because of the surface area. Now a 4x10, again, traditionally designed 170 millimeters squared. 4.5 by 10 is 235 millimeters squared. A 5.0 by 10 is 308 millimeters squared. And a 5.5 by 10 is 388 millimeters squared. Now remember these three numbers here. 4.5 by 10, 5.0 by 10, and a 5.5 by 10. Look at the surface area. 235 here on the 4.5, 308 millimeters squared on the 5.0 by 10, and 388 millimeters squared on the 5.5 by 10. But again, you're only making a 3.3 osteotomy. Why is that important? Because more importantly, you're using each implant relative to each patient's type of bone regarding the density and the ridge thickness. Okay, here's a great slide. These here are your molar type implant sizes, and here's your normal type implant size. And let's do a quick comparison. Everybody, one of the most popular sizes in all of implant dentistry is a 4.0 by 10, right? Where's my cursor? There it is, 4.0 by 10. So this happens to be an external hex implant. it has about 152 millimeters squared on it. A 5.0 by 10 has about 198 millimeters squared surface area. Now, one of the most popular molar size of implants on the rescue we utilize is, where's my cursor again, is a 7 by 7 millimeter diameter implant, 7 by 7. And that implant has 231 millimeter squared surface area. Now, what do we say a 4.5 by 10 has? 235. So just a 4.5 by 10 has more surface area than a 7 by 7 rescue implant. So that's a big piece of titanium here. All right, so macro view of the Anyridge implant, again by core, is your, again, 4.8, 3.3, and 2.8 particular core. Again, 2.8 is 3.5, your 3.3 core is 4.0 through 5.5, and your 4.8 core is 6.0 through 8.0. All right, so typically people think, and again, we're conditioned to think this way because, you know, bigger's better, but that's not necessarily the case with the Anyridge. You think these type of big fat molars are necessary in the posterior versus something like this. And again, that's not necessarily true because of the surface area that we just talked about. So let's specifically talk about the 5 millimeter Anyridge fixture in the posterior. So is it adequate enough for strength? Again, look at the surface area, 308 millimeters squared surface area. So because of the thread design and the minimal core 3.3 core removal of bone, you're actually getting much more increased surface area. This is a 5.0 by 10 Easy Plus. This is our own comparison here. Here's a 208 millimeters squared surface area. This is our Easy Plus that we just showed you earlier. 5.0 by 10 Anyridge has 100 millimeter squared surface area more, 308. So a 5.0 by 10 is absolutely more than capable of holding a molar because of more surface area and the better initial stability. But there's one thing we can't forget, okay? Implants are not all the same animal, and this will kind of illustrate that, as we've, again, throughout history and known regarding implant designs. A straight-walled implant has nice sort of pressure or force transfer down the length of that, where's my cursor again? Down the length of the implant here, okay? A tapered implant more has like a wedge effect, if you will. So it not only puts pressure down the length of the apex of the osteotomy, but the sides as well. Now, when you look at an Anyridge, the thing that you have to consider, again, you're taking minimal bone preservation away, but you're also engaging, look how wide the threads are, okay? You're also engaging all that bone, which adds to the stability of what we're looking at. So again, don't just look at the macro design of the implant. Look at what you're engaging as well. Look at the width of the threads versus these type of threads. Much bigger difference, much bigger outcome in the stability. And here, this is almost like a, what they call it, visual tolerance. Look, here's a 6.5 by 8.5 implant in the posterior maxilla. It's an Anyridge, as you can see. But it's really not, because of the core being tapered, you envision the implant being tapered, but it's really not that tapered. When you take into consideration the width of the threads, again, it's really not that tapered. It's a small taper to it, yes, okay? But again, having that lack of taper to it actually adds more to the surface area, so the thread design actually adds a ton to the surface area of the implant. Now here's a case. Here's a implant that failed. It's a Straumann tapered effect that failed. So this is it grafted and healed over. And we had minimal surface area to the sinus. So this patient didn't want a sinus lift. So here we're doing a flapless technique. I don't always condone flapless techniques, but here we're going to show one. Here's your tissue punch. And there we're going to go ahead and remove your tissue punch with your molt. Go circumferentially around it. Use your stopper drills, which are really nice. Again, especially when you're close to the sinus. Where's my cursor again? There it is. Here's your hub here, as you can see there, and there's your stopper drill itself. So your hub always stops you from going down into any sort of anatomical structures, and these drills do harvest bone nicely as well. Okay, Now also, here's your cortical bone drill, which again, we're going to show in just a second here a little bit further, but I'm just showing a clinical case now. Here's your ratchet adapter in place, actually driving the implant down into place, and there's your minimal sized healing abutment, okay? So here's your actual implant placement there. Again, this is a 5.0 by 8.5. We did not perforate the sinus. Plenty of surface area to hold up a molar implant, okay? And you're already starting the tissue training with the healing abutment there. All right, so it is a revolutionarily strong implant connection. The pull-out force on your 5-degree Morse taper is almost double what the closest competitor is, which is a Bicon. The Bicon has a 1.5 or 3-degree taper if you multiply that times 2. And the Straumann has an 8-degree Morse taper, or 16 degree when you multiply that times 2. And the Anyridge has a 10-degree Morse taper, which again, 5-degree Morse taper times 2 is 10 degrees. So the pull-out force is almost 15 kilograms of force. So double what the closest competitor is. When you actually remove the screw from here, you cannot remove the abutment from the implant. It actually takes an abutment removal abutment removal tool to remove the screw. And let's look at the physics of the connection itself. So it is, again, an internal hex here, as you can see there. There's your 5-degree Morse taper here. Okay, and it does, again, provide a perfect hermetic seal. We call it the Magic 5. And again, with the internal hex, the beauty of all 10 diameters of implants is they have the same connection, which makes it a common connection with all 10 diameters of implants. So here, and again, the most important thing to remember about the connection is the female screw acts to only engage with the implant. Once you torque the abutment down into place, no stresses are being put on the screw itself. So let's look at that. Again, here is your internal connection there, and there's how it seals up against the implant, and there's your screw. One thing to note, notice there are threads here and here. So there are actually threads in the abutment. So once you remove this screw from the actual implant, then you have, with your driver in place, you also have to lift up and unscrew the screw from the abutment as well. Remove the screw and then put your abutment removal tool in here, and I'll show you that in just a second. But here's your connection there. It's revolutionary strong, and again, you do get a perfect hermetic seal around that, clearly. All right. So with your abutment in place, again, you do get a cold welding effect clearly, and it is a very definitive connection. So now let's look at we've looked at the sort of physics of the implant. Now let's look at the actual surface treatment of the implant itself. We do have a revolutionary surface called X-Speed. It is stronger, faster, and it's safer. We start with an RBM implant. It's actually a super RBM implant with a particular blasting agent, which is resorbable blast media, and then it is acid etched. Okay, and then we take that implant and put it through a hydrothermal process, and it results in the X-Speed surface treatment. So the actual implants are now color-coded blue once the treatment has gotten onto the implant. So here you see an animation of the treatment itself. Again, it is a hydrothermal treatment. I can't really tell you the chemistry behind it regarding the bone apposition and so forth, but it is a very hydrophilic surface that, I mean, I've seen great bone adaptation and so forth rather quickly to the X-Speed surface, much more so than the RBM surface, that's for sure. Okay, so the reason it's stronger is because, again, the removal torque test of the implant after a couple weeks in place is higher than the SLA. I don't want to get a lot into the surface treatment itself other than it works phenomenally well. Bone to implant contact is also increased, which adds even more surface area to the osteotomy. And here's a great slide. Here's your RBM surface, here's your SLA surface, and here's your X-Speed surface. Your bone to implant contact, or your bone fill, is, again, look at all the bone fill after 2 weeks. Now, again, you can't, this black area here and here and here and here, this is all the bone in between the implant itself. So that bone is absolutely key, again, for a very, very definitive primary stability aspect. So you're not just relying on the surface for integration. Again, you're also relying on the actual primary stability of the implant with the unique thread designs, as well as the surface. So you're really double dutying this implant. So we've talked about the central core design, we've talked about the 5-degree Morse taper, we've talked about the knife edge threads, and we talked about the strong body with wider surface area. All right, so what we haven't talked about is your round and tapered apex area with no cutting surface down here, and then your double offset for better peri-implant biotype and maintenance. So let's look at that. Okay. So the Anyridge implant system really has a blunt apex for non-perforation of vital structures. Now what I was talking about earlier is the implant really doesn't redirect itself. These implant designs can redirect themselves in the osteotomy, and they can also perforate the sinus or perforate the IA canal. So that's something you really want to be cognizant of. Whereas this round blunted edge actually serves well to lift the sinus membrane versus cut it. And again, these thread designs, the thread design are key. So again, with crestal bone preservation, some do, some don't. This one does, so does the Anyridge. But really what's unique about the Anyridge, again, is you have the knife thread, you have the definitive connection with the 5-degree Morse taper, 3.5 to 8.0 diameters of implants with 0.5 millimeter increment in each implant diameter. The initial stability is phenomenal, and you have zero screw loosening. It's very rare for you not to get 40 to 50 Newton centimeters of torque with these implants very easily. All right, quickly to go over platform switching and just to kind of define what that is. Here is your old prosthetics here, and notice how the implant diameter is equal to the actual abutment diameter. And this is platform switching, where the implant diameter is actually more than the abutment diameter. So your abutment diameter is what, again, the definition of platform switching is medializing the implant to abutment connection, as you can clearly see here. Okay, so that's a macro view of it. Again, what that does is give you extra bone apposition as well as tissue, more tissue to be able to have a better final outcome. All right, so let's look at Nozawa's observation. There is a vertical component as well as horizontal component to obviously the end result with implants, as we discussed earlier. What do implants do for the tissue and the bone? So after you place the implant, you typically get just a bit of remodeling around the area, okay? And what you really have to do, and look at the aspect of the vertical component of the tissue as well as a horizontal component. It is typically a 1 to 1.5 ratio, okay? So what does that really mean, and how can we achieve that even better with the Anyridge system? Okay, so basically, to summarize everything, is a lot of lecturers are using this term now. The tissue is the issue, but the bone sets a tone, right? So wherever the bone wherever the bone is, the tissue follows. All right. So here we clearly see where a connective tissue graft was done, and bottom line is, just like we talked about earlier, maintenance is key. Can these pink aesthetics be maintained over time? So how to maintain it best over time without losing those pink aesthetics. So let's talk about the 3 important design factors relative to the Anyridge, how it makes your life even easier. All right. From a biologic point of view, just like we discussed about Nozawa's observations as well as Salama's, here again, because we're preserving more cortical bone, you actually have more bone thickness, which ultimately the end result is more tissue thickness as well. Okay, you so basically have a double offset here. So with a smaller consistent core size and then a platform switch there, or what we call the S-line prosthetics, which we'll get to in just a second, you actually have a much better soft tissue result as well as bone result versus trying to push the envelope. Again, as the implant diameter gets bigger, your bone removal actually gets bigger because your drill gets bigger. And you typically, again, only have 0.7 millimeters of thread engagement, which is 0.35 on each side. So you're really relying here on the surface as well as the microthreads to keep the bone in place versus actually saving the bone. So the consistent core size for more crestal bone and blood circulation in area. So that's really key again. The more bone you're saving, the more blood supply and so forth you have to the area as well. This is what I'm talking about here when I was talking about the S-line prosthetics here. You have a much, because of the anatomical cup design, you actually have thicker mucosa, which obviously ends up with more keratinized gingiva, which is key. And then this bevel on this implant here, as well as the surface roughness to the top, again maintaining your bone level implant design. So bevel on implant with surface roughness to the top actually maintains bone, which ultimately again maintains your tissue. So the end result is here's your traditionally designed implant here, and here's an Anyridge. So again, thread designed, peri-implant biotypes actually being increased here because of your double offset design there. Again, keratinized gingiva is key and much more increased, much more so in the areas with utilizing the Anyridge implant because of everything we've already just talked about. All right. So implant design is important, like we basically opened up the lecture with. Now here, again, you see an anterior case, especially in the anterior, this type of not only initial stability, but where you countersink the implant, and the design of the implant is key. Because you typically, when you place an implant in the anterior, you typically place that 1 millimeter lingual to the cingulum of the adjacent teeth, as you can see here. Now, we talked about the biotypes earlier, and again, you want to maintain that buccal plate by adding just a little bit of bone there as well. Okay, you're able to do that easier with these designs of implants, again, because of the lesser amount of bone that you're removing with the increased stabilization with the thread designs. All right, and again, a macro view of that. So again, double offset, everything that we just talked about and so forth, I went into great detail with that. So what are we looking at from a prosthetic perspective? Adequate peripheral seal or Morse taper, eliminating the micro gap. Stable medialized implant to abutment connection, again, platform switching, no micro movement. Proper load distribution throughout the connection, avoid basically the loading of the screw. All right, and we talked about that earlier with the physics and the connection of the implant itself, which is phenomenal. So all things considered, let's look at some cases here. All right, so here's a case, and I just want to flip through these because we have some more drilling guide and so forth to go through. Here you actually have this patient had a buccal defect on the area, so we had to lingualize the placement slightly. Here you can see a CT graft, obviously, of the extraction socket itself. A CT graft, a CT scan. Here's a 5.0 by 10 implant. Okay, now notice how we place this implant just a little bit deeper than normal. Typically this implant is 1 millimeter below the crest of bone, but because of the defect we place it slightly below that. But note the bone, where the bone is there and where the bone is there, and again, very small healing abutments. Okay, and you can see here it's below the height of bone, but again, here's your healing abutment there. We didn't want to put a large flared healing abutment on there, because what would happen if you put a large flared healing abutment there? Basically, you're squeezing up against the bone and you'd have problems. So we wanted everything to heal nicely, and here it is. I believe it was about 4 months later, healed up. We went to go restore the case. Now, how do we do that with your healing abutments? I mean, with the Anyridge system, the healing abutments are key. Here's a big set. This is compliments of Dr. Jerome Smith. This is a big 7.5 by 11.5 super wide implant, but look at the big fat healing abutment on there. Okay, we're going to go over that in just a second. So, and just to point something out, this healing abutment here is compatible with this implant here. Like we talked about earlier, there's only one prosthetic connection on all 10 diameters of implants. So everything is universally compatible. This 10 millimeter flared abutment will fit on this 4 millimeter diameter implant. Okay, so, but I'm just pointing this x-ray out to you to show how the healing abutments are key in your soft tissue training and basically your emergence profile. Again, compliments of Jerome Smith and Dr. Darrell Berg. So the secret to this system is really the healing abutments and how to use them. Okay, again, 4, 5, 6, 7, 8, and 10 millimeter flares. So as the tissue heals, you want to start with a small healing abutment to give obviously the area more circulation in the soft tissue itself, because you don't want to compromise the blood circulation in the tissue either. But then as time goes on and the tissue matures, all you do is switch out the healing abutment to a little bit bigger and a little bit bigger to the emergence profile that you want. That's again, controlling your aesthetics that way. Again, this is a good example of those. Now, let's get back to that case we just showed. So here is a 4mm diameter healing abutment. And here, again, you have a little bit different view of it. So what we did, we took the healing abutment out, but look at your soft tissue gingiva. I mean, it's just beautiful around that, nice and pink, stippled, and lots of keratinized gingiva. Okay. So what we did immediately, we took that 4 out and put a 6. This says a 605, which means a 6 flare by 5mm cuff height. But you can see what happens to the tissue. The tissue blanches. Okay, that's great. It's not a problem. Just give it 10 minutes. Wait till the patient goes ow, and then you come back, or you can numb up the patient. It's up to you, but you don't necessarily have to. And wait till the patient goes ow, and then after that blood circulation and so forth comes back in the area, just hand tighten down your healing abutment just a little bit more. Okay, wait till the patient goes ow until that healing abutment is seated all the way. And obviously the healing abutment looks like this. Or if you want to put it in and wait for the patient to come back like a week later and so forth, you can. So now, again, when you remove this healing abutment, this is the way the gingiva is going to look. And again, nice, thick, stippled, keratinized gingiva. Okay? So one of the things prosthetically to mention, again, that we mentioned earlier, is there's no more small platform, regular platform, or wide platform to be dealing with. There's only one prosthetic connection, which is truly liberating from a prosthetic perspective, because it makes your life a lot easier. You no longer have to call me up and say, hey Joel, I need a small platform or a regular platform or wide platform impression coping, because if it's an Anyridge, there's one connection for all of them. So here's a UCLA abutment. You can tell here's your custom cast abutment. It has a facial groove on the line on the abutment for orientation. Okay, and here you can see the restoration on the crown. So we remove that after checking the contacts, doing your occlusion check and contacts and everything else. Everything was great. We went ahead and torqued the abutment in place. We sealed it off with some I believe it was polyvinyl siloxane that expanded in the area, and then we removed that little excess there. Now again, here's a great x-ray of, and this is, compliments of Dr. Jacqueline Allen in Phoenix, and the restoration was done by Cosmetic Dental Arts in Albuquerque, New Mexico. Again, you can see the height of gingiva there. Beautiful, again, super keratinized gingiva. Nice. The bone is exactly where we left it, except for that little area there, which again you're going to remodel right to the top of the implant, which it did, as you can clearly see. And there's a final restoration in place. Okay, so the aesthetic design and again, that double offset really affects the prosthetics that you're looking at with that S-line, that S-line prosthetics, as well as the internal hex and the 5-degree Morse taper. Again, definitive connection that gives you the best end results. We do have lots of different prosthetic options for you relative to overdentures and so forth. One thing that I want to mention, again, because there's one prosthetic connection, there are different diameter final abutments. There's a 4mm diameter final abutment. This is mainly for your laterals, your 5.0 and 6.0, which your 5, by the way, the circle with a little line through it means diameter. So 5.0 and 6 or more, like your medium-sized abutment. So you want to think of these as small, medium, and large. So your 5s are more for your bicuspid, canines, central incisors, so forth. So this is more laterals. And obviously the 7 is specifically for molars, dependent upon the tooth size itself. Okay, here's what I was talking about earlier. Here is your abutment removal tool. Remember, we talked about this screw coming out and actually disengaging not only from the implant, but disengaging from the threads here. So then after you remove that screw from the connection, obviously you're not going to be able to remove the abutment from the implant. You then get your abutment removal tool, and notice there's threads here. So this driver will fit into the implant. You turn it clockwise. Your threads will engage the threads here first, then they'll engage the threads on the implant. It'll bottom out on the implant and then lift up on the abutment, and that's how you remove the actual abutment. Again, because of the definitiveness of the 5-degree Morse taper, you absolutely need the abutment removal tool for this process. Okay? And easy posts also come in 2, 3, 4, and 5 millimeter tissue cuff heights. Again, everything that's a final abutment will utilize your abutment removal tool. One question I get all the time is, what's the blue screw in the package? Well, guess what? You get a free lab screw in the package itself. Now, your gold screw is for your final prosthesis. Your blue screw is for your lab screw. Now, again, any final abutment has this blue screw in it because you're not going to need it for temporary abutments. So quickly, your transfer impression copings, your closed tray impression copings come in 4 and 5 millimeter flares. Your pickup impression copings come in 4 and 5 millimeter flares as well, but they also come in a 7 millimeter post height or height as far as the access goes. And again, it comes in 7 and 12. Depends on how much the patient can open up, and sometimes you use those, sometimes you won't. Again, here's your prosthetic options quickly, and we just want to cover some more stuff regarding the drilling guides. All right, so full prosthetic overview. Another one from Dr. Jacqueline Allen. Here's the implant in place. I'm quickly going to burn through this. Here's your healing abutment. Here's your transfer impression coping. There's your soft tissue model from the lab, and you can see how the emergence profile is built into that transfer impression coping. Okay, and again, nice where it's basically very easy to remove once the PVS or polyether sets up. Okay, here's your final abutment, and it's a custom cast abutment, again by Cosmetic Dental Arts. Beautiful abutment. You can see in just a second there's actual anti-rotation built into the abutment, which is ideal as well for your facial groove, and there's also anti-rotation in the crown. So he did a great job restoring this case. The technician's name is Mike Sumner. Beautiful crown there. We went to go ahead and cement the crown, but now how we're going to remove all that excess cement from the area. Okay, so by the way, notice here's your blue screw, your lap screw in there, and there's your transfer impression coping seated, and here's a picture of it not seated. You always want to take an X-ray to verify your impression coping was seated all the way. Now here's your impression coping in place. You're never going to do that like this, however, without an analog. You're always going to want to put an analog onto your impression coping and then reinsert it into your full arch impression. Okay? All right, now, how are we going to remove that cement like we talked about? Break off one of those Q-tips, get the little wooden stick there, a little pin or toothpick, whatever you have. Put some blue mousse material inside the actual crown itself, and we're going to make a custom die. All right, once that sets up, you remove it, and what do you have? Again, you have a custom die for the inside of the crown. So why are we going to use that? Once we actually mix up the cement, so we're going to use that die to remove the excess cement. Let's remove the healing abutment. Nice tissue that we talked about. You can see the tissue there. Nice emergence profile. Custom abutment being seated with your facial groove, straight facial. Okay. There's your blue lab screw coming out, and your gold final screw going in. Again, you can tell that that abutment was nicely seated into the connection because we just removed it without the abutment coming off. Okay. So there's your crown. And now we're going to torque this baby into place. With this implant, you're going to range anywhere from 25 to 35 Newton centimeters, because with the Anyridge system, there is really no set torque amount. 35 is plenty, 25 is plenty, again, because of the definitive nature of the 5-degree Morse taper. So a range from 25 to 35, depending upon your torque, your torque wrench that you may have. Different systems work very well with the MegaGen system. Meaning different torque wrenches work very well with the MegaGen system. Now here's, we used a, what's the name of it? Duralon material. And we mix up your cement, put that in there. And again, now typically all that excess cement would be going underneath the tissue, all right? But what we did is we used a little quick tip, and now we got our custom little die that we made and put that in there. And obviously we had already put the cotton and so forth, or PVS in there. We wiped off the cement, the excess cement from there, and then we actually did it again. Now you can clearly see there's less cement in there, and you can kind of see the walls where it's just painted onto the actual the crown itself. Okay, so again, look at your excess cement there that's coming out. We actually did it again, so a little bit more came out. So when we seated it, no excess cement came out, and therefore no excess cement ended up underneath the tissue, which is very, very nice technique. Now, I want to throw this in here as well. The UCLA, in my opinion, it's the best abutment for aesthetics. You have the definitiveness of the metal for the strength. And this, again, it was done by Mike Sumner in Cosmetic Dental Arts in Albuquerque, New Mexico. Here's your UCLA, custom cast, wax, and everything to the natural emergence profile and so forth that you want, tissue cuff height and everything. And then they actually bake porcelain to the actual abutment. Okay. For zirconia crowns, whatever the case may be. There's your bisque bake try-in, and then your final crown being seated. Okay, now let's go over the drilling aspects and really tie everything that we talked about into what we're doing here with the Anyridge system. So the basic principle of the Anyridge drilling sequence. Now, the drilling sequence and final drills can be decided by the surgeons according to his or her preference. Very important concept that we're going to need to talk about. Soft bone, not so much. Dense bone, we really need to talk about. Your D1 bone, well, let me just read it from the top. Soft bone. The super self-tapping threads have a single core diameter that facilitates minimal site preparation by utilizing a smaller osteotomy to place a wider fixture with special threads. We talked about that, 3.3 and 4.8 cores, right? So hard bone or dense bone protocol. The osteotomy socket drilling should almost reach the widest size of fixture to avoid sticking in the bone. And then the last thing we're going to talk about here, the best way to get initial stability with the Anyridge system is by placing an implant with handpiece. And you want to use a handpiece with plenty of torque, leaving 1 or 2 threads above the crest at 40 Newton centimeters. Okay? Then use a ratchet adapter to place the implant to the desired position. Now, what does that mean? Here's a great example. Here's an implant that was placed. And here, this is, again, courtesy of Dr. Daryl Berg. This doc actually had dense bone at the top, so he just went ahead and got the 4.8 stopper drill and went in and used a stopper drill similar to a cortical bone drill. Okay? And then he placed his implant. This is a 5.0 by 11.5 implant, but look at the crest here. Again, relative to the bone and how much basically resistance he was getting because of the cortical bone, he just basically made room for your implant to go in without basically getting stuck. And you'll see what I'm talking about in just a second. But that's still preserving crestal bone. Here is another picture, and this is relative to the best way to get ideal initial stability with the Anyridge system is by placing the implant with the handpiece, leaving 1 or 2 threads above the crest at 40 Newton centimeters. Again, because your handpiece gives you a consistent torque amount. Then use a ratchet adapter to place the platform in the desired position. So if you place the implant right to about here, or maybe just a little bit deeper at 40 Newton centimeters, you're good to go. But if you have this implant sticking halfway up out of the bone, like up here for instance, you don't want to continue placing that implant. You want to back that implant out and drill your osteotomy out, or go to a smaller diameter implant, because you're not going to force this implant into place if you have a lot of cortical bone in the area. And again, you'll see what I'm talking about in just a second. So soft bone and dense bone protocol relative again to the Anyridge system and how to place that to depth. Now, one thing we haven't talked about yet, but this is absolutely key. Let me first talk about the literature. It has been proven in literature that 0.5 millimeter to 1 millimeter subcrestal placement shows better crestal bone response. With the Anyridge system, a fixture that goes down to the ideal position without further drilling, avoiding damage to the important anatomic structures. Okay, so the actual length of the 3.5 diameter implants to the 5.5 diameter implants is actually 1 millimeter shorter than the written length. Okay, that ensures that your implant has the variability to place it either at the crest of bone or 1 millimeter subcrestal. But again, it's ideal if you place it 1 millimeter subcrestal. So the actual length of the 6.0 through 8.0 super wide diameter implants fixture is a 0.5 millimeter shorter than the written length. Okay, so let's talk about that and show you a little particular slide here. All right, so the actual length of the fixture from 3.5 to 5.5 is 1 millimeter shorter than the written length. For 6.0 through 8.0, again, it's half millimeter shorter than the written length. And again, it's already built into the system for you. You don't need to do anything but drill your osteotomy. Your first mark is 7, your second one is 8.5, your next one is 10, 11.5, 13, and the last one is 15. Okay? All right, so what are we talking about here? So your implant's going to go into place, and it's going to be placed subcrestal, as with this implant here. So what you really want to look at is, again, place your implant relative to 1 millimeter below subcrestal. But you also want to look at your CEJ. Where's your CEJ of your adjacent teeth? And do you have enough prosthetic room for your natural emergence profile and for the laboratory to make you a nice restoration as well? So you always want to take into consideration also your adjacent teeth and your CEJ. So what is the most important factor or point for your drilling for the Anyridge? Excuse me. It's really the actual drilling process as well, to be able to find out what the bone density is. You really need to be able to predict or know what the bone density is. And again, D1, D2, D3, and D4. So D1 is pretty much cortical, D2, D3, and D4. All right, it's bone density, as we just discussed. You can kind of do a test if you want. It's a really kind of good test to utilize. You don't want to do this with your Lance or your 2.0. You want to wait till about the 2.9 drill and utilize this drill, as its design and cutting features are a little bit different than the others. So after you do your Lance and after you do your 2.0, get your 2.9 drill and then do that with this. You can find out what the bone density is by utilizing your motor at 50 Newton RPM, or sorry, at 50 RPM and 50 Newton centimeters without irrigation, okay? And again, you can judge and find out what your bone is by that process. Now, D1 bone is going to be white bone without blood. D2 bone is going to be white bone with little blood. D3 bone is going to be red bone with blood. And D4 bone is going to be very spongy bone with blood, okay? Now, here is a picture of D1 bone. Now, forget about this part here, because this part is basically just seepage from the actual oral cavity. But if you look down the osteotomy here, it is white, white, white. Tell me, are you going to try to place a big, fat, super wide implant in this? Even your smaller diameter implants, you need to be careful of, and you want to stay conservative with. With this type of bone, you definitely don't want to place even a 5.0 implant unless you drill out the osteotomy even more. But then you have to pay attention to the ridge width. It's all relative to two things, your bone density and your ridge width. Okay, you have to take into consideration your ridge width as well. So let's look at your drilling sequence. Again, your marking drills are long, your stopper drills are shorter, and they're already cut to length. Again, 2.0, 2.9, 3.3, and 4.8, both in stopper drills and your long marking drills. And this is relative to your 2.8 core, 3.3 core, and 4.8 core. Again, taking bone density and everything else into consideration. Your D3 and D4 bone is a little bit different. Your drilling sequence and final drill can be skipped by the surgeon according to bone density. And you want to look at that. Again, D4 bone, for example, you can actually skip the final drill in D4 bone, because the final drill would be for this implant, Lance 2.0, 2.9, and then 3.3. Okay, because the reason you can tell that, because this is a 3.3 core with a wider thread engagement. But can you skip this final drill? Depends on the bone, okay? And here's a great example. This implant, this is a 5.5 by 8.5, and the reason we went with an 8.5 is because here's your sinus right there. And this patient, again, did not want to have a sinus lift or go anywhere near the sinus. We placed a 5.5 by 8.5, but the final drill that we stopped at was 2.9, and we still got 50 plus Newton centimeters of torque. All right, so these are the things you're going to have to take into consideration looking at your different bone densities and your drilling aspects with the Anyridge. One of the things to look at and utilize a lot with is your cortical bones. So after you made your osteotomy with whatever size drill you're going to finish with, and you do have some dense cortical bone at the top that will not allow you to place your implant to depth, simply use your small, medium, or large cortical bone drill, okay, and you place it right to the hub. Again, you want to think of this as small, medium, and large. So your small is only for your 3.5. Your medium cortical bone drill is really for your 4.0 through 5.5, and your large is for your 6.0 through 8.0 type implants. But again, actually 6.0 through 6.5. And the reason is because your wider, super wide implants, again, are mainly for extraction sockets, which we're going to talk about again in just a sec. So here's a mistake, and this is why basically we're harping on this, and this is a long presentation. Because here's a mistaken case of density, bone density, excuse me, by placing a super wide implant in D1 bone. Now look at this implant here. This is a 6.5 by 7, all right? And mandible, it was D1 bone. And it was done flapless, by the way. Super wide implants, mainly for extraction sockets. If you're going to use these in a virgin site and you want a big honking implant for a patient who's a severe bruxer and so forth, you can place these. I would place either a 6.0, 6.5 with your drilling protocols. Okay, and we'll go over that again in just a second. Your 5.9 drill is the final drill in the Anyridge kit. One thing that we haven't talked about either is, and this will make all the sense in the world in just a sec, the final diameter of the implant is 6.5. Yes. However, due to extraction sockets, okay, and the nature of extraction sockets, how they sort of come out like an ice cream cone or a teepee looking thing, inverted teepee, is your, where's my cursor? There it is. Here's your widest part of the implant, which is actually 0.4 millimeters bigger than the final diameter. So not to confuse you, let's go over the chart. Your 3.5 is actually outer diameter is 0.5 millimeters bigger at the top thread, so that makes it a 4 millimeter diameter. So your top thread is right here. Okay, so the 4.0 is 4.4, 4.5 is 4.9. So the rest of them from 4.0 on are 0.4 millimeters bigger only at this thread right here. And again, that is because of the nature of extraction sockets. You want to make sure and get that extra stability in extraction sockets. So that's why we have a little bit basically built-in insurance policy for you to be able to get great stability in an extraction socket as well. So now that we know that, let's go back to the stuck implant. As we see here, where is it stuck, right? So this drilling sequence for your 4.0 and 4.5, taking everything what we just talked about into consideration as a final diameter. So your 4.0 is really a 4.4 at your widest diameter, which is here. Your 4.5 is really a 4.9 at your widest diameter here. So here it's showing you the sequence of 2.0, 2.9, 3.3, 3.8, 4.3, and 4.8 for your final diameter of your drill. However, again, do you want to always do that? My point is with the Anyridge is stay conservative. Try it. If it gets stuck, back it out and use the next drill bigger. Okay? Because you don't want to drill out the osteotomy too wide, or else then you have to go to a different implant size. So again, it's all relative to the density of bone. Now, the question is 0.1 millimeter thread enough to get initial stability? Again, the secret to this implant is stay conservative. D1 bone is very dense bone, but again, you want to stay conservative with this implant. So with your super wide implants, here's your 6.0 implant. The final drill is a 5.9. So here's your full drill sequence that you went through here. And here also is your cortical bone drill. And here's a great example. Here, like we talked about, when you're placing this implant, and actually you're placing this implant to depth, like we just talked about, relative to final placement. There you see the implant being placed subcrestal. After you, remember we talked about after you place your implant and it goes into place, it's a little bit sticking up, then go ahead and grab your ratchet adapter and your ratchet and go ahead and place your implant. Now this is not the final x-ray of this particular patient. However, this is illustrating the depth that you go, and it's 0.5 millimeter to 1 millimeter subcrestal. Okay? All right. So please remember, very, very important, the fixture diameter is 1, but then the widest diameter of the actual thread is another. So only the top thread has that widest diameter. So again, if it's a 3.5, add 0.5 to it. and that makes it 4.0, but only at the very top. The 4.0 through 8.0 is 0.4 millimeters wider at the very top. Okay? This is Dr. Park and his team in Korea, and Dr. Park invented the Anyridge implant system, so I want to give kudos to Dr. Park. He is considered the king of implants in Korea. He has over 40 patents that we can talk about. This brings us to the very end of the presentation. I know it was long, but there were so many things that you can see to talk about that I didn't want to pass up anything and make this a very, very comprehensive presentation. So thank you very much. I appreciate your time, and I hope we can discuss things with you in the future. Please call me or email me at your convenience. Thank you very much. Take care. Bye-bye.